So my talk was really focused on how to manage general medical inpatients that have psychiatric illness. And the reason why that's so important is that estimates show that about 40% of medical inpatients that are admitted for a medical reason actually have a comorbid psychiatric illness. And we know that patients with primary psychiatric illness actually die about 2 decades earlier than the general population. And so it's really important to make sure that all clinicians are equipped to both recognize and treat psychiatric illness. Yeah, great question. So I talked a lot about depression and how to differentiate that from demoralization. Demoralization is something that we see really frequently in the inpatient setting, but is not necessarily considered a primary psychiatric illness. It's something that is almost kind of a normative part of going through something as distressing as being admitted to a hospital. So I talked about depression, I talked about anxiety, I talked about somatic symptom disorder. I also talked about things like psychotic disorders, and then I also focused quite a bit on substance use disorders, which is something that we see really frequently in the inpatient medical setting. The number one thing to keep in mind is that patients want to be treated in this non-judgmental way. They often experience bias and judgment in the rest of their lives related to mental illness, and so when they're admitted, being able to kind of be treated in a way that is equitable and in a non-judgmental way is I think the number one principle to keep in mind. And then really just being able to recognize that they're experiencing not only medical illness, but also psychiatric illness, and that psychiatric illness is medical illness, and being able to make sure that we are treating all of their disorders and not just focused on their medical illness. Yeah. So I talked a little bit about when I talked about mood disorders and particularly depression, I mentioned in my talk that a discussion of depression is really incomplete without talking about suicidality, just given the severity both suicidal ideation as well as completed suicide. It's estimated that about 1 to 2% of completed suicides in the US occur in general medical hospitals, and so not insignificant. And the Joint Commission has really identified this as a sentinel event that needs to be, paid attention to more than we have in the past. And so, what many hospitals do is utilize kind of formal standardized screening tools, one of which that I mentioned during my talk is the Columbia Suicide Severity Rating Scale. That can often be helpful to identify some of the safety issues that occur for patients experiencing psychiatric illness. So suicidality is definitely something that all clinicians should be able to kind of recognize and manage, or at least know when to reach out for help when they know that their patients are experiencing it. But something else that I talked a little bit about was the management of agitation, which can often occur in the general inpatient setting, either due to primary psychiatric illness, although agitation violence is quite rare in patients with psychiatric illness. They're much more likely to be the victims of violence rather than perpetrating violence. It is something that we see in the general medical inpatient setting because patients with things like psychotic disorders often feel very disempowered, very paranoid, very fearful, and can exhibit agitation. And as a consultation psychiatrist, I also see agitation in non-psychiatric illness, such as things like neurocognitive disorders or delirium. Yeah, great question. So it definitely, more than patient to patient, it kind of varies in terms of what location you practice in terms of what mental health resources are available in the community. And so, unfortunately, due to kind of years of stigma, psychiatric care was kind of separated out from the rest of medical care. And, we experienced such a shortage of mental health resources in the community in many areas of the United States. And so that's definitely one of the big challenges. But really kind of recognizing that if a patient is experiencing mental illness, it is not unlikely that they'll experience an exacerbation after an acute medical hospitalization. And so making sure that they have follow-up. So that can be a therapist, that can be another mental health clinician. It can be a psychiatrist. It can be a primary care provider. And sometimes for patients, community leaders like religious leaders are often helpful. And so helping the patient help the clinician identify what resources would be helpful in the community to be able to continue caring for them kind of more holistically and making sure that their mental illness is cared for is kind of the most important.